Okay, so in the last session, we talked about bacterial skin infections, and in this session, we look at infections caused by viruses, fungi, and parasites. Again, we will, by the end of the lecture, you should be able to identify some more common and important skin and soft tissue infections caused by viruses, fungi, and parasites, and describe their pathophysiology, clinical presentation, treatment, and prognosis. And it'll help you provide a differential diagnosis for any skin rash that looks like an infection. So we've started a 58-year-old hypertensive diabetic patient who presents to the emergency department with a rash on the torso. She says that this started as a pain on the right side of her chest 3 days prior, and this morning she noticed blisters to the right side of the chest. This is a picture of the rash. It's a little bit blurred, but you get the point. You can stop the video, consider what this is, and think about what you know about the condition. So of course this is herpes zoster, caused by the varicella zoster virus, a type of herpes virus. It's really a reactivation of the virus. People would have contracted the condition in childhood, probably as chickenpox, or sometimes asymptomatically. The virus then sits dormant in the dorsal root ganglia, and in certain conditions gets reactivated. So conditions which would increase stress on the patient or reduce their immunity. So it's definitely seen in older adults or people with poor T-cell immunity and other immunocompromised patients, particularly those with lymphocytic leukemia, but of course also those with HIV or on immunosuppressive therapy. And it's also associated with some very specific chronic diseases such as inflammatory bowel disease, asthma, rheumatoid arthritis, COPD, chronic kidney disease, and depression. Just a little bit more about this condition in immunocompromised patients. There are two other situations that are really important. So, if you see somebody with a single dermatome affected, it's usually just some transient stress, physiological stress that they've undergone that reactivated the virus. However, if you see somebody with multiple dermatomes affected, then they need to be investigated for underlying immune compromise. And as with eczema herpeticum, you can get widespread rashes covering the entire body in patients who are severely immunocompromised. With the normal herpes zoster, this presents as a painful area of skin corresponding to a single dermatome, usually affecting the torso, and the thoracic dermatomes are the ones most likely affected. Of course, it tends to be unilateral. After the pain, we then see erythema and erythematous papules, vesicles, and blisters developing. Treatment, by and large, is symptomatic and supportive. However, if the condition is caught within 72 hours of rash onset, antiviral agents such as valacyclovir will reduce both the duration and the severity of symptoms. The common complications include bacterial superinfection, post-herpetic neuralgia, which can be quite troublesome and which may require specific treatment, or these may be related to the specific nerves affected, particularly cranial nerves, so things like Ramsay-Hunt syndrome or herpes zoster ophthalmicus, in which there are really specific complications such as, in Ramsay-Hunt you get facial nerve palsy. With herpes zoster ophthalmicus you can get corneal ulcers. You need to read up on those things. Patients may develop meningoencephalitis, and as I said before, you can get widespread dissemination in immunocompromised patients. Case 2 is a 7-year-old child who presents with an itchy rash on the hands, feet, and groin. Have a careful look at that and tell me what you think it is. You may pause the video. Again, think about what else you might know about the condition. This is scabies, caused by Sarcoptes scabiei, the human variant. Remember that mange, or mange as people call it, in dogs is also caused by Sarcoptes scabiei, but a different variant. This is a common, highly contagious skin condition that is seen in children particularly, but may also affect adults, particularly adults who look after children. And it tends to present as very itchy papules, vesicles and blisters in the interdigital spaces of the hands and feet or in the groin creases, typically, that may develop into burrows, which are pathognomonic of the condition. In some immunocompromised patients, or in the elderly and in those who are immobile or have debilitating neurological disease, they can develop something called crusted scabies, which you would have seen in the presentation on blistering skin disorders. Again, it's something you need to know about because it is a common exam question. That's the crusted scabies. Treatment is topical antiscabitics. There's a sort of procedure. You have to treat the entire skin surface. You have to treat everybody in the household. You need to wash the sheets and other things that may have onto which the scabies might have shed. Bear in mind that the common means of transmission is skin-to-skin contact. So scabies can be considered as a sexually transmitted disease, although of course that is not the only way to spread it. The typical complications are bacterial superinfection, and if that infection involves group A beta hemolytic strep, then patients can develop post-streptococcal acute glomerulonephritis. Here's another case. A 26-year-old tourist comes to the department with itchy rash on her arm, says it's been there for the past week, and it appears to be moving. Stop this video and have a look at this funny old rash. See if you can figure out what it is and what you know about it. This is cutaneous larva migrans. It is an infestation with a species of hookworm that does not usually infect humans. And what happens is the larvae, as does human hookworm, penetrates the skin of the host, but because it's the wrong host, it can't complete its life cycle, and it stays subcutaneous, migrating around the body under the skin. The most common organism implicated in the New World is Ankylostoma brasiliense, which is a dog and cat hookworm that's seen in both wild and domesticated species. But these other three that I've listed here are also common in different parts of the world. And as you can see, it's not just dog and cat, it could be cattle hookworm as well. So you get this serpiginous rash, and if you go back to the picture, you realize it looks like a little worm crawling under your skin. It migrates across the skin with time, and it is highly pruritic because this is a serious antigen under the skin. The treatment is to use topical antiparasitics such as ivermectin, thiambendazole, or metronidazole. These things can get secondarily infected. Patients, because it's such an allergen, patients can actually develop more systemic allergic reactions to it, and very rarely the larva migrates into the lung, not through the blood, but actually crawls down your throat into the lung and can cause something like Loeffler's syndrome. An 8-year-old is brought to the emergency department with a lesion on his scalp. This is what it looks like. A two-week history. Stop the video, see if you can figure out what this is. Yep, so this is a dermatophyte infection, or Tinea capitis. I've listed the more common types of fungi that cause it, or the genera anyway. They tend to live in the stratum corneum of the epidermis and are supported by moist, warm skin. Patients who are immune compromised, such as those on immune suppressive drugs or patients with HIV or diabetes are more at risk. And specifically for tinea corporis, it tends to be common, or slightly more common, I should say, in adolescents and pregnant females. So the name of the condition varies a little bit with the area affected. Treatment can be oral or topical, and the drugs used are azoles and allylamines, and you actually need to go and look up the pharmacology of those two groups of drugs and the common drugs used. Oral treatment is reserved for those with persistent, resistant, or recurrent infections, but is the first-line treatment specifically for tinea unguium and tinea capitis. Okay, so that was just a short view of some non-bacterial skin infections that you are going to come across. Of course, as always, this is just a brief introduction. I expect you to go and do some further reading. So in summary, we talked about some non-bacterial infections, including herpes zoster, scabies, cutaneous larva migrans, and dermatophyte infection. If you have any questions, you can bring them up in class. Thank you.